Well, good evening, everybody. We thank you for joining us, and we're glad that you're here. Father Leon sends his regrets and is unable to join us tonight due to another commitment, but he asked me to warmly welcome everybody, so thank you for being here and welcome. One quick housekeeping. For those who are not familiar with our parish, the restrooms. The restrooms are in the back. There's a restroom where I'm kind of directing my arm, and then there's another restroom where I'm directing my other arm. So they're in the back there. October is the Right to Life month, and we believe it appropriate to offer this presentation this month. Tonight's presentation is entitled Ethical and Religious Considerations at the End of Life. We thank our Respect Life Committee and the Institute for Healthcare Ethics for co-sponsoring this event. The Institute for Healthcare Ethics, or otherwise known as IHCE, is a nonprofit organization here in Buffalo that promotes ethical practices in healthcare through education. We will have 3 speakers share with us their unique perspectives on these end-of-life issues. Each will present for 10 minutes apiece, and then open it up to questions for the last half hour. I'd like to introduce Dr. Scott Monte, Clinical Assistant Professor at the UB School of Pharmacy. Dr. Monte graduated as a Doctor of Pharmacy in 2006. He will focus on the importance of advanced health care planning from his perspective as a member of the sandwich generation. I'd also like to introduce Dr. Joseph Caruana, MD. Dr. Caruana is a physician and clinical ethicist. Dr. Caruana received his undergraduate education at Canisius College, now University, where he teaches biomedical ethics to undergraduates. He attended the SUNY Medical University in Syracuse and did his residency in surgery at the Erie County Medical Center, also known as ECMC here in Buffalo. He is a co-founding member of the Institute for Healthcare Ethics. Dr. Caruana will speak to the potential dilemmas of practicing Catholics on specific end-of-life issues. And then I'd also like to introduce Dr. Phillip A, PhD. Dr. Reed is a professor of philosophy at Canisius University, where he works on ethics, applied ethics, and moral psychology. His primary research interests in bioethics are the doctrine of double effect and end-of-life issues. He is currently writing a book refuting any ethical basis for provider-assisted suicide. Dr. Reed is a member of the Ethics Committee for the Catholic Health Care System here in Buffalo and of the Ethics Committee at Erie County Medical Center. His attention will be on the alternatives to provider-assisted suicide, which is opposed by Catholics and others. I ask you to please bring your hands together and welcome our 3 distinguished guests.
So good evening, everyone. We are obviously going to cover quite a lot of territory. As the far youngest member of the panel, I'm going to open with sort of as with that nice introduction we'll tie through a topic I don't think we talk about a lot. UB actually just did a full session on this relatively shortly ago, and it is the sandwich generation. Only 50% of the people in this room know what that term means. Do you know how I know that? I have a magic AI chat machine that told me this afternoon, so it cannot be wrong. But even if you do not know that term, the sandwich generation, or even if you do, let me tell you a story. I wrote a story about a man. He's now in his 40s, although he looks like he's still in his probably mid-30s. He's still looking pretty good. He had a good childhood. Not much money, but he didn't know that he was poor. His parents divorced. but he had a lot of community support, good families, ended up making his way to college. Finished up college, began on the path of his life. Ends up meeting the woman of his dreams, gets married in his late 20s. 3 kids into his early 30s. But then life happens. All of a sudden, those kids want to start doing things. A lot of things. Expensive things. Time-consuming things. And in this window, the parents get excited. They become much more engaged. They're excited for the kids. The birthdays, the holidays, the emergency situations when there's nobody else around to watch the kids and we need a night out. But inevitably what happens with the sandwich generation is we thought we had planned. With great forethought, we put our life plan together. And then all of a sudden we realize when one of our parents takes ill, we did not do a good job of planning whatsoever. All of a sudden, Dad gets a little bit sick. His mobility starts to fade. His cognition starts to slip. He's not quite as sharp. He can't get out of the house. Getting to doctor's appointments is a real problem. His new wife bears that responsibility until she can't. In our generation, the kids are the foundation of that sandwich. And then when our parents can no longer take care of themselves, we are pressed in between, trying to figure out how to navigate a life that is now much different than the one that we had thought we had planned. So if I came into this evening with one objective, it would be that parents young, of my age, and parents old, of any age, begin to think about the difficulties that may rise. We don't talk about these issues in our 40s. We don't talk about these issues in our 50s. This session is around end of life. But these conversations need to begin happening in our 40s and 50s. I reflected on this a lot thinking about this session. And I really have 3 perspectives that I think I've gained in this last year or two since that decline has happened in my parent. The first is, as a parent, that I would never want to lay this burden at the feet of my children. The second is as the child. I'm, of course, compassionate for what he's going through. But if I'm honest, I'm mad. How did he let this happen? Why is this falling at my feet in the middle of having everything else that is at its maximal time capacity in life? We have 3 kids to manage. How did this possibly happen? But then I think of his perspective. The final perspective. This is supposed to be the best years of his life. He's been robbed in some way. He doesn't get to experience all the things that he wanted to experience. And so, what have I learned? I learned that I wish I would have done this 20 years ago. I wish I would have had conversations 20 years ago. And I would have to admit that I was aware that I needed to have conversations. But for whatever reason, I didn't take action. There was no impetus for me or motivation for me to take from my current life to move to what I thought could be the future. And now we live as a sandwich generation, pressed between 3 kids that have to go all over the state and all over the country and move them around in all the pieces that go at 5 o'clock at night until 9 o'clock at night. If there's any parents in here or grandparents, you know there's no end. Right? There is no more once-a-week activities. There is no more twice a week sports. It is 4 to 5 days a week full go for whatever activity it is that you dream up. So we are pressed to try to figure this out, and if we don't communicate to educate younger people on having these conversations, we will not escape from the sandwich generation. And that was my hope from this conversation as I talked with Dr. Caruana, Dr. Reed. Said the thing I'd like to walk away today is that 1 or 2 or 10 or 20 people go home and either think for themselves, what have I not done to perhaps spare my children the burden that are coming? Or to the opposite, if you are young, motivate yourself to take action, because you will spend the time now or you will spend the time later. And I think the quality of time can be very dramatically different. And with that, I will hand over to Dr. Caruana.
Hello, everyone. We decided that we'll take questions and discussion at the end, if that's okay. So if you think of something you want to ask Scott, maybe just recall or remember it. I also would like to thank Father Leon, as well as Brian and Mary, for hosting us. As you know, this is Respect Life Month, which means respecting life from the moment of conception, which when we may not exactly know when that occurs, we do know that it does occur, to a natural death. And that's an issue which I think we want to focus on today. What does it mean for there to be a natural death? And Scott, I think, has very eloquently told you about the issues which warrant advanced care planning, discussing with your children as well as your surrogate or your healthcare proxy what it is that you would like and what it is that you would not like at the end of your own life, so that people are very clear about that. I think ideally we all would love to die at home, and that would be surrounded by our family and our friends, having made our peace with God, having received adequate treatment for the condition we had, and to be free of any discomfort, whether it be mental or physical. I'm very impressed with something I'm going to pass around. We decided we did not have a slide to be able to show, but this is, I'd like to pass it around. This is a painting made by someone you may have heard of. His name is Pablo Picasso, and he did this when he was 15 years old. You want to take a look at that? It's called Science and Charity, and he is depicting a scene of a woman dying. She looks to be of middle years. She's surrounded by her physician who's monitoring her pulse, a nurse who's offering a drink, some comfort, and the nurse is holding a child. And you can probably presume it's the patient's child. So she's surrounded by her family. She seems to be very peaceful. The bed is well made, the room is clean, and she seems to be quite taken care of, quite comfortable. That is kind of an ideal way of dying. Unfortunately, now many of our relatives and us die in hospitals, and this is where the issue becomes important. I've been struggling with a little bit of a cold, but I'm not as bad as Phil, so we're both working our way through some laryngitis. So what happens when we get to the hospital, or our relatives, our loved ones get to the hospital? And we now have an option for treatments and technologies which may not have existed just a short time ago. What is the role of these newer technologies and new treatments, and how do they relate to a natural death? What does that mean anymore? What does it mean to have a natural death when you're surrounded by all this technology? When treatments and technologies are beneficial in reversing an acute condition, by acute we mean something which comes on quickly and we hope will resolve quickly, they're certainly warranted to take advantage of. But when a treatment or a technology is going to prolong life without any real benefit to be anticipated, we would probably call that futile treatment. A short time ago, I gave a lecture on futile medical treatment to ECMC, and we had an audience of providers, nurses, doctors, and I asked how many people in the room think that giving a patient futile medical treatment is unethical. There was a huge show of hands. And then I asked how many people in the room think that we actually give futile medical treatments to our patients. And again, there was this huge show of hands. So it's a dilemma. We think that it's not ethical, but we do it. And why do we get in this situation? Some reasons I think are very legitimate. Some patients need to have time for their families to reconcile with an illness. Sometimes siblings need to come together and resolve some issues among themselves. We've personally seen at ECMC sometimes conflicts and dilemmas and confusion among children be resolved at the time of a patient's death. So this is important to use this kind of end-of-life time, and I wouldn't call it be futile. But sometimes we get families who say they want everything done. This often happens when the patient now does not have the ability to speak for himself or herself, and we're now talking to their healthcare proxy or their surrogate. And I guess the concern that we want to address tonight is, what is the Catholic perspective on end-of-life care and the use of these technologies? Well, fortunately, we have a document which has been circulated now for about 2 decades called the Ethical and Religious Directives for Catholic Health Care Services. This is now in the 6th edition. The first was around the year 2000. This is primarily directed at Catholic institutions, healthcare institutions, but the lessons I think can apply to all of us no matter where we seek medical care at the end of life. Ethically, the document states that decisions by the designated surrogate should be faithful to Catholic moral principles and the person's interests and values. So the document clearly supports a surrogate decision maker at the end of life. And this is what Scott's referring to when he says, talk with your kids, talk with each other, make sure people know what you want, what you value. These decisions at the end of life should be free and informed by the person or the person's surrogate. Further, there's a whole section on issues in care for the seriously ill and dying. And this is something that I want to kind of stress. Obviously, if you have issues for yourself or a loved one in the hospital, and you feel you need to have the input of a clergy member, I'm sure Father Leon would be available to help, or the chaplain at the hospital. But I want you to know that these guidelines are available for anyone to read. In the preamble to this chapter on issues in care for the seriously ill, they state that it is the duty of we have our duty to preserve our life and to use it for the glory of God. But the duty to preserve life is not absolute. For we may reject life-prolonging procedures that are insufficiently beneficial or excessively burdensome. That would be our definition of futile medical treatments. There's even more specificity about some very practical things. We used to talk in the earlier versions of this about extraordinary and ordinary treatments. Nowadays, the extraordinary has become ordinary. And the language has now changed to talk about proportionate means, are those which are, in the judgment of the patient or the surrogate, offer a reasonable hope of benefit but do not entail an excessive burden or expose excessive expense on the family or the community. There's often a discussion at the end of life about medically administered nutrition and hydration. The document here clearly states that they may be morally optional if they cannot reasonably be expected to prolong life, or again, whether it would be an excessive burden. And another final point here is this idea of withdrawing treatment. What do we do if somebody's on a ventilator and we see that a ventilator is a breathing machine, usually with an endotracheal tube, and we feel that there's no benefit? The document clearly comes down on the point of the ability to withdraw treatment if, again, it is not providing any benefit that will help prolong life. The document, of course, is based on the idea of Imago Dei, a Dei that we are made in the image of God, and human dignity is paramount to be respected. How am I doing for time? Just about done. I just want to say a brief word about the idea of praying for miracles. I've personally witnessed that on one of my experiences at the hospital when I was doing palliative care, and Phil's going to talk more about palliative medicine. A patient was obviously dying on a ventilator, had been so for a long time. The family was basically making a round-the-clock novena with the Virgin Mary and altar and flowers, and it was clear to me that this person was not going to survive. And I just felt that somehow something was wrong with this picture, that people were praying for a miracle when it was really the best miracle would have been for the patient to expire. So I'll stop there, and Phil's going to talk about some alternatives, including palliation and maybe hospice.
Thanks. I'm going to stay seated so I can look at my notes more easily. I want to thank St. Greg's and Dr. Caruana for the invitation to be here this evening. First, I want to just tell you a little bit about physician-assisted suicide before I discuss some ethical alternatives. So, in general, in a pair of Supreme Court cases from 1997, the court ruled that the issue of physician-assisted suicide should be left up to the states. So there is no constitutional right to die. The court ruled several decades ago. Since then, 12 U.S. jurisdictions have legalized physician-assisted suicide. Now, the laws do vary from state to state, but in general, there's conformity and there are restrictions on eligibility. Most importantly, in all the U.S. jurisdictions, in order to be eligible for assisted suicide, the patient has to be diagnosed with a terminal illness, which means they have a life expectancy of 6 months or less. In addition, they have to be capable of ingesting lethal medication themselves. In no place in the United States is it legal for a doctor to administer a lethal injection, which is sometimes identified as euthanasia, in contrast to assisted suicide. That's different from other jurisdictions, such as Canada, where a doctor's action to kill a patient directly is legal. In 2024, the Oregon Health Authority reported that 376 individuals died by ingesting lethal medication prescribed by a physician. So that's a small number. It's less than 1% of all deaths from Oregon in 2024. And I mentioned Oregon just because it was the first state to legalize it, and it's the state for which we have the most data comprehensively. So the numbers have grown gradually, but they've remained relatively small in U.S. states. That's somewhat different in Canada, where the numbers have grown more rapidly since they legalized euthanasia in 2015. Right now, about 4.7% of all deaths in Canada are from legalized assisted suicide or euthanasia. Now, in our state here in New York, there's been legislation introduced annually since 2015, and the legislation got significant momentum in 2023 from the New York State Bar Association when they endorsed the legislation, and then in 2024 when the Medical Society of the State of New York endorsed the legislation. So as you probably know, the bill passed narrowly in the legislature this year, and it's awaiting Governor Hochul's signature or veto by the end of this year. It has a similar structure and safeguards as other U.S. states, but it is different and more liberal in that it has no residency requirement, and it's the only statute in the U.S. that has no waiting period to acquire the lethal drugs. So that's background on where we stand. Now, as was mentioned in the introduction, the Catholic Church opposes assisted suicide and euthanasia. There are non-religious reasons to be opposed, but I will omit those for the sake of time and just let you know that fundamentally the Church teaches that these kinds of acts trespass against God's authority over life. The idea is really that it's up to God, not to us, when we should live or die, and we should view life as a gift. You know, the idea of taking your own life or asking someone to do it for you is an expression of ingratitude and rejects the gift of life that God gives us. In addition, too, the Church teaches that there's absolute prohibition on intentional killing, and obviously suicide and euthanasia is a violation of that prohibition. I'm quoting here from the Catechism of the Catholic Church. It says, "Whatever its motives and means, direct euthanasia consists in putting an end to the lives of handicapped, sick, or dying persons. It is morally unacceptable. Thus, an act or omission which of itself or by intention causes death in order to eliminate suffering constitutes a murder gravely contrary to the dignity of the human person and to the respect due to the living God, his Creator. The error of judgment into which one can fall in good faith does not change the nature of this murderous act, which must always be forbidden and excluded." So, even though the Church has this strong teaching against what is likely to become legal in the state in the very near future, nevertheless, we can understand a lot of people's fears, I think, about the end of life. And we should think about what the ethical alternatives are. I think a lot of people fear suffering at the end of life for understandable reasons. We fear that we'll be in unbearable pain. We fear a prolonged dying process that's extended unnecessarily by technology in the way that Dr. Caruana described. And I think it's important to mention that Catholic bioethics has resources to address these fears. One of these, of course, is hospice and palliative care as ethical alternatives. And here, the dying process is made bearable by palliating the patient's symptoms. The Catechism also says that palliative care is a form of disinterested charity. And I like that description. I remember some years ago reading an article by a theologian, the title of which was Why I Want to Be a Burden on My Children When I'm Older. And, he argued that his kids were a burden to him as he raised them, and it's only fair now to extend that to his kids in his old age. And there's something to that idea because, part of the motivation for assisted suicide and euthanasia is the understandable fear that we don't want to burden our loved ones. But we have to also understand that, being a human being is about neediness and dependency. And all of us experience that at different stages of our life. And we're there to help each other through those stages, as we did with our children when they were young. And then as they do with us when we can't completely care for ourselves. So I think that is that sort of point of view and philosophy is carried out very well in hospice and palliative care, including in Hospice Buffalo here, which has promised not to participate in physician-assisted suicide. Now, their position is that they will not prescribe or administer, obviously, lethal drugs to patients, even if requested. And that's a tradition going all the way back to the Hippocratic Oath, where doctors pledge not to directly kill their patients. However, they are also not refusing patients who want to die by so-called medical aid in dying. And that's in part because they want to show patients that they can help address their fears and their symptoms at the end of life and reduce their suffering and give them a reasonable quality of life, even in the dying stage. So their hope is that people who intend to ingest lethal drugs will come to Hospice Buffalo, and they'll realize that they don't need to do that after all. Dr. Kelly Clem is here from Hospice Buffalo and can speak more about that point of view and their position on it in the question and answer. The other thing, too, I want to mention is that this is sometimes confused with the church's position. The church does not teach that you have to do everything possible to keep yourself alive. Okay, and again, Dr. Caruana discussed when it's ethical to withdraw or withhold treatment for patients. There can be cases when that treatment becomes extraordinary, such as when it's futile, but also when there's no benefit, as he mentioned, when there's excessive effort, or when it's extremely burdensome or painful, or when there's high expense, or even sort of fear and repugnance associated with the treatment on the part of the patient. So there are lots of ways in which patients can determine enough treatment. You know, I'm not that kind of action to forego medical treatment, even if it does cause the patient, in some sense, to die because they die by their condition, by their illness and disease and their pathology. Nevertheless, it's not equivalent to suicide or euthanasia. And so these have to be kept ethically distinct. The act of withholding or withdrawing treatment that results in death, and then the act of intentionally causing the patient's death through lethal drugs. So I'm happy to answer any questions about the New York bill or assisted suicide and its alternatives more generally. Yep.
Just before we open it up, I would just like to say a word about our Institute for Healthcare Ethics. We formed it several years ago. Scott and Phil are board members, as is Mr. Charlie Sellers and Mr. Vince Mancuso, who are in the audience. And if you'd like to know more about us, they can speak to it. The purpose of the Institute was to try to improve healthcare through education and the ethical delivery of healthcare. So that's what we've tried to do tonight. Just to summarize, what we're hoping from tonight is that you, speak with family members about advanced care planning. There are resources available on the internet and elsewhere. Everyone should have a healthcare proxy, which is probably preferable to something that's called a living will. So healthcare proxy would be important for you to designate someone to make decisions if you are unable to, and discuss that with your family. We try to give you some references to information about the Catholic Church's position on end-of-life issues. As Phil Reed summarized, the Church doesn't say we have to do everything to prolong life. If it's too much of a burden, that's not something we need to do. And we also heard that there are alternatives to ending one's life, particularly with hospice and what's called palliative care, which is treating a person's symptoms at the end of life. So we've tried to give you the education part of it and let you know about resources. If you need to know anything more, you can certainly come and ask us, or also look at our website. We'd be happy to have you look at that. I think now we'll open it for questions, and Mary has the microphone. My understanding is that the microphone is important for people who are watching this at home. I might want to start with Dr. Ralph Doerr, who's an associate I've known for a long time. Ralph reminded me that he's currently working as a trauma surgeon in Rochester, and he's got an Irish perspective on things, as I recall.
Well, that's good.
I do have a story, Joe. This was when I think I was still working for you at the VA, but I had a woman who I had operated on, and she was very slow to recover, and it became but I felt that we could pull her through. She was on the ventilator, and I got together with the family, and they were adamant. They said, no, she's suffering, and take the tube out. And so I struggled with that, and we even got the ethics committee, and they said, no, you have to honor what the family says. And I said, no, I can't do that. And so what I did was I then transferred her care to another one of the physicians, there in the ICU, and he promptly removed the tube, and she expired. And I remember thinking, and to this day, very long ago, I think I did the right thing by my own, my own upbringing and my own faith, but I'm not sure. It was a very compelling argument. They say, no, she's suffering, and you have to end her suffering. And I said, well, I'm sorry, I just can't do that. And
2 quick points, if I could follow up. You should know that all hospitals have ethics committees, and if there is an issue that you're finding some disagreement with among yourselves as family or with the patient or the providers, you can ask for an ethics consultation at the hospital. And the second point is that doctors have consciences too, and we're following our conscience, and Dr. Doerr did exactly the right thing. You transfer the care to someone else who's willing to take over. And that can even happen at the institution level. If a hospital feels they can no longer proceed with a certain treatment, they're obligated to find another hospital who will care for that patient. Any other questions? Mary? Or Kelly, rather?
So I'm not a plant, an audience plant, but I am the patient advocate for hospice and palliative care here in Buffalo. And I appreciate the opportunity to echo what Dr. Reed had said. I've been fearing this day and this year for the 30 years that I've worked for hospice, knowing that at some point we would have to decide as an organization whether we would agree to or participate in the whatever term they used. We went from physician-assisted suicide to medical aid in dying, and all of those nice words that really just sort of camouflage what we're really talking about here. So I am so grateful to our Lord because He answered my prayer and my miracle that we would do the right thing. So hospice is not going to participate in medical aid in dying, physician-assisted suicide. We are not going to kill patients. We never have. Many people fear the medications that we use, but we use them safely, and I can attest to that. I would not work for an organization spiritually. I would be like you, Doctor. I would not be able to engage even if someone tried to convince me that it was the right thing. So we will not participate. We will not prescribe. We will not administer. But I think it's an important point for everyone to know that because we're accepting patients who are telling us that some won't tell us. Some are just going to do so, and I'm sure they already have. Some are not going to, some are not going to share with us that they're going to be doing this. But those who do, it's important to know that we are not going to turn them away because we truly believe in those miracles that we pray for. That our ability to manage suffering, our ability to talk to them, and to showcase what being a caregiver is in this time, the grace that fills the room in those moments is something that cannot be dismissed. And if we have even one opportunity to save one life from making that decision because we were able to make them more comfortable, we've actually done it twice. We had 2 people that were going to leave the state and were going to go and engage in this, and they changed their mind. God changed their mind because they knew that they were able to be comfortable here without having to make that choice. So I just encourage you to talk to hospice and palliative care if you're in that situation. We also have a perinatal program, which I think, this is Right to Life Month. So we have the other end of the spectrum where people are being diagnosed with children in utero, and we take those children in so that the abortion doesn't have to happen, and we follow them through their pregnancy. And so Hospice and Palliative Care Buffalo is truly a right to life, even though they would never say that, because they believe in the quality and the sanctity sanctity of life for however long that life is supposed to be here. And I just wanted to say to Dr. Monte, I know you're angry now, but we did a tremendous study on the gratitude of people who were just in your position, and it's something I want you to read, because to have the burden and the grace to take care of parents while you're trying to raise children, it was pretty profound what we were able to discover. So hang in there, you're doing a great job, and thank you to these fine people for that, and thank you for letting me speak.
I know, if I can just interject, I'm the Respect Life Coordinator here at St. Greg's. My name is Mary Pisarczyk, and we just had our diocesan in service, and hospice came and did a presentation, and one of the things that I came away with is it's one of the most underutilized services that is offered, and yet they have so much to offer. So we have to do a better job of publicizing and letting them know what these people do and how much help they can be. Sure.
So I had a question to Dr. Caruana. Can you give us the exact title of the document that you read from?
This is available. This is the Ethical and Religious Directives for Catholic Healthcare Services. It is the 6th edition. It's available online. You can search for it and have it downloaded. Again, are directives for Catholic institutions, but I think it's applicable to all of us. The sections are sixfold. Including social responsibility of Catholic health, pastoral and spiritual responsibility of Catholic health care, the professional-patient relationship, issues in care for the beginning of life, issues for the seriously ill and dying, which I referred to, and something having to do with healthcare organizations. Here, I'll show you. We thought about having slides, but that was going to be a little hard. I want to share just a quick story, unless Mike, or you want to say something? Go ahead.
I don't know where if they have that position on it yet. Again, this hasn't become law yet, so but I'm not sure. There is as Kelly mentioned, there is a conscientious refusal to participate. Any provider that doesn't want to does not have to in the bill. So it may be left up to individual physicians who work at an independent living center. I'm not sure they've taken a position as an organization.
I'm more wondering, where do they stand for their clients? Do they say, yes, your life has value, and right, we're not going to allow them to go ahead and take your life? Right. We're not going to permit New York State to be able to do that. Is that, I mean, they haven't stated what their position is one way or another. Correct?
Not that I know of. No, maybe Kelly knows, but
I don't think. At this time, I think every person's just sort of jockeying and figuring out their talking points, yay or nay. But I don't think that there's going to be any location or organization that's going to sanction it. I think it's going to remain a private physician motivated or generated act. I think there's just too much political fray either way, and I also think that there would never be consensus amongst a physician group, I would say. So I think they're just probably going to leave it to a private entity.
I will just add one point, which is, and then turn it over to Dr. Monte, but Among the staunchest opponents of this bill, aside from the Catholic Church, is usually disability rights organizations, and these are people who fear that the sort of slow disregard for human life for people who are not as autonomous as adults in the prime of their life, and so they tend to they've spoken out very forcefully against the legislation, in addition to the church. So.
Yeah, the question struck me as really insightful because in independent living, I work for one of the medical groups in town that does home visits and probably manages maybe 60 or 70% of the independent and assisted living facilities in the area. And it often is one provider that is handling the care for maybe 60 or 80 or 100 people. But what's important on that perspective is there's never 100%. The community physicians are still penetrated, and there's still always an ability to navigate or hand off to another provider. The more interesting scenario is what happens in skilled nursing, where there really is one predominant provider. So I thought that was really a very interesting question. I don't know exactly what the answer will be, but working with this group of maybe 50 medical providers, I think there is going to be a range of acceptance, and really it's probably going to come from the leadership of those entities to drive sort of what the practice is going to end up being.
The other thing is, for different religions, there's a different meaning for death. Some religions say as long as your heart's beating, you're still alive. It doesn't matter what brain activity you have. If you even have a brain, as long as your heart's still beating, you're still alive.
Yeah.
And so there's so many different avenues that you have to look at that way as well.
Yeah, we did have a roundtable on it at one of our weekly meetings where all the medical directors are there, and they posed a question, well, what if this legislation goes through? And it was really just like anxious head nodding. I don't think anybody really wanted to think about how they're going to handle that at a bigger level. So yeah, thanks for the question. That was a good one.
I was just wondering, as a surrogate, I'm one of six. I have 5 siblings, 6 children. My parents do have a living will. They have health proxy. But the living will, to me, seems, it's very generic. There's some things that are listed out specifically that, they don't want this, and they don't want this, and they don't want this. But as technology changes and treatments change, what happens when you have the gray area that there's things now that they weren't presented with when they signed this living will? That how do you determine if it's something they would or wouldn't have wanted?
Among ethicists, living wills are basically discouraged because they're usually made when people are well and they can't quite foresee into the future of how they're going to feel about something at the time. There's been some studies showing that only 30% of people do have a living will, and many of them don't apply anymore, or they can't even be found when someone is ill. The much better option is to designate a health care proxy. Remember, you make your own decisions as long as you're able. The health care proxy is someone who will make your decisions based on your values, knowing you, if you are unable to do that. And that would be whether you want to have a tube, whether you want to have feeding, whether you want this cancer treatment or whatever. Ethically and morally, the healthcare proxy cannot countermand what you had specifically said based on what they think. Okay, they have to basically be your agent. If someone does not have a healthcare proxy in New York State, there then is a surrogate, and the surrogate is first a spouse, then children based on their ages, etc. So a surrogate is someone who stands in for you if you don't have a healthcare proxy and you can't make your own decisions. Those are the terms. So living will, healthcare proxy, surrogacy. If someone has no relative, no one to speak for them, then it's up to the physicians caring for them to make a decision based on what they think is in the patient's best interest. Did that answer your question? So again, living wills are limited, but a healthcare proxy is much better. And as Scott says, a family conversation, talking among yourselves about what I would want in this situation. Go ahead.
how do you determine what's, and who does? And maybe it's this, I mean, I'm listening to the ethics committees that you have and the consultation that you could request. How do you know what's extraordinary or what's too burdensome when if you're the healthcare proxy making that decision?
Can I use an example from what I believe Pope Francis did? Okay, Pope Francis was in the hospital and was very ill, and as far as we know, he probably had the ability to make decisions on his own. But I think that Pope Francis probably had a do not intubate order in his chart. From what we heard, and I know Ralph's physician, there may be other physicians here, we were told that Francis aspirated at least twice, which means some emesis, vomitus went into his lungs. The treatment for that is intubation. Put the patient on a ventilator, clean out the lungs. My supposition is that he did not want that. And they then treated him with the next best thing they could, and he managed. And what's fascinating is that as sick as he was, he seemed as though he maintained his autonomy to the end. He basically chose he was going to die on Easter Monday. I thought that was just an amazing example. We talk about John Paul II being an example of suffering, but I think Francis was an amazing example of how to manage end of life. I don't know if that answered your question, but that was an aside.
Yeah.
I think some decision, if you know, obviously, if you know the person you're representing well and their values and their wishes as they've expressed them to you, some decisions are easy, but not all decisions are easy. And there are going to be cases where, there's no formula for identifying an extraordinary or burdensome treatment. There are going to be cases as a proxy where you don't know what the person would have wanted, and you have to make a hard decision about it. There are things that you can do to help yourself through that decision, perhaps call an ethics consult, rely on those close to you, rely on the opinion of the providers as well, are things I would recommend. But even in all those cases, there will be cases where the decision is difficult. And my view is that that's part of the burden that you're bearing as a proxy, is making a decision that sometimes you don't know what's best, but you do the best you can. So, and of course rely on God's help too, insofar as
pray that you make the
right.
decision. How many people actually go through with what they put in a living will? And I ask this because my mother had surgery. She had a complication. We're taking her a couple months ago to the hospital in an ambulance, and the ambulance driver asked her, "Do you have a living will?" And she said yes. And it said, "Do not intubate, do not this, do not do that." But when push came to shove, she told them to forget the living will and do whatever it took to keep her alive. So how effective are they when push comes to shove and they're making that decision and they choose not to do that because, like you said, they were well when they made it and they didn't want to burden their children and they didn't want to prolong things. But then when push came to shove and they were going to do it or not do it, she said, "Do anything you can."
Right. So two things that I'd like to say. First of all, the living will is something you might write now about what you anticipate in the future. There is something called a medical orders for life-sustaining treatment, called a MOLST form. All right, that's where you actually have specific orders that the doctor signs based on the patient's expressed will to him of what he or she wanted, and one of them might be, "Do not intubate me." All right. Those are the things that sometimes the EMTs will ask for when you come to the house. Do you have a MOLST form? They may not ask about a living will. They might ask for the MOLST form. But even that one, the patient can revoke it right up until they can't speak anymore. The ethical issue comes when the patient can't revoke a MOLST form, but now the healthcare proxy does. That throws ethics committees for a loop. But as long as the patient has awareness and capacity, we call it, to make a decision, they can override what they had previously written.
Two things on the MOLST form, just because they make me very nervous. MOLST forms are hot pink, so you never lose them. Two things. One, the original intent, it was Dr. Pat Bomba in Rochester actually started the whole process. that is used nationwide now. But the first thing is that it is intended for a physician to sit with the patient and explain all of those things, not encourage them to choose either way, but it is medical orders, and it has become morphed into a nurse social worker conversation with a physician signing afterwards. So hold fast. If you have a good relationship with your physician and they have been caring for you, I highly encourage you to have that conversation with them. Secondly, there is no policy or process for how often you review it. And that is the issue, because as medical treatment changes and as people change, that form should be pulled out regularly to say, does this still apply? Is this still what I want? Does this physician still think that these are legitimate, given my condition? So those two things I can assure you are not happening in our community, and we need to really resurrect the purpose of it and the process for using it.
I was just going to make a comment. I was a member of ECMC's ethics committee. I worked there for 30-plus years. And when you're talking about healthcare proxies, it's great to have one, but it's also really bad to have one if you have 2, 3, 4 people signed on as your healthcare proxy, because then it just becomes a war. One healthcare proxy can say, we want this, another one can say that. Pick one person, please, just one, that you trust knows your intent and can follow through on your wishes. Adding so many other people to it, I don't want to just have one of my children be it. I want all of my children to be it. It's going to end up poorly.
And ideally, if there are multiple children, the one who's designated should be known to the others, and they should understand that that person has the sole authority. If you were on the committee, you know that many times someone comes in from out of town, hasn't seen mom for 10 years, and says, oh no, we got to do everything. I don't care what you say. That puts up a lot of... Having a healthcare proxy doesn't resolve every issue. I think there was a question over here, Mary. What? Why don't we? Mm-hmm.
Because when I had my stroke, I had to do that with the doctor. Go through and actually answer everything and get the actual definitions of things. And if this is what I wanted, if something happened, and then it had to be brought out anytime I was in the hospital for anything and re-signed.
Exactly right. That's the medical.
It is pink, and it's on the front of my refrigerator.
Right. Should head you up here.
One short question. Does health insurance cover palliative care?
Palliative care? Go ahead, Kelly.
Palliative care is covered by, here in Buffalo, Uvera, Highmark, and Independent Health is kind of going over some stuff, so we're not sure which way. But, and Medicare Advantage program. So if you have Medicare through a private insurance, palliative care is covered. Straight Medicare and straight Medicaid do not cover palliative care in total. They will cover the physician or nurse practitioner consult, but they won't cover the nurse, the social worker, the volunteer, and other ancillary departments. Hospice Buffalo is a not-for-profit, so that does not mean that if you don't have the right insurance, we won't help you. We will. But palliative care nationally is not covered by Medicare or Medicaid at this time. There are demonstration projects going on to make that a reality, because you don't have to be dying to get palliative care. You simply have to have symptoms that are related to a chronic progressive disease. Hospice is covered in total by any insurance, and if you don't have an insurance, Hospice Buffalo will take you regardless of your ability to pay, and it's 100% free. There's no charge for any of that.
I think that's the sign that we have now
The bell's ringing.
all going to turn into a pumpkin. Was that 8 or was that 12? We agreed that we were going to keep you only for an hour, so why don't we quit? But I think the three of us will stay, as I hope Mr. Mancuso and Mr. Sellers will stay, if anybody wants to know more about the Institute or what we've said. And Kelly, you might want to stay also. Thank you very much. Brian, did you want to say anything? Okay, thank you.
Certainly want to thank everyone, for these three wonderful gentlemen for being here tonight. We've talked a lot about the New York State potential for the physician-assisted suicide. Our pro-life group throughout the diocese and through the state is trying to get people to sign petitions. I have a bunch. If you haven't signed it already, when we had it at our table last weekend, I would really appreciate it. What we're going to do is hand deliver them to Kathy Hochul, say we don't want this here. If we can she hasn't signed it yet for whatever reason, so we've got some time. So if anybody would be willing to do that, I would appreciate it. Come see me. I've got them. I've got pens. I've got paper, and just have to put your name and address, and we'll take them to her and hopefully change her mind.